Hello and greetings to all my friends and colleagues in the Society of Critical Care Medicine. I am really very honored to be with you today. And as I think many of you know, I'm a pediatric intensive care physician. Started coming to SCCM probably around 1987, 1988, and was a participant at least through 2004 when I did my first stint in the federal government. I'm very honored to be here and privileged at an unprecedented time. We're in the middle of a pandemic, something that all of us thought was possible and all of us really prepared for most of our careers. But I think none of us really expected we would be in the midst of one right now in 2020. But here we are in the middle of a pandemic with unique challenges to all of us, whether we're doctors, nurses, pharmacists, social workers, administrators. No matter who we are, we're all affected. We're affected personally, we're affected professionally, and I appreciate the opportunity to be here with you.
When we look at resource allocation, that is, how do we take the things we have in order to care for the patients under our responsibility? These get traditionally organized into three large categories: stuff, staff, and space. So stuff are the things we have, the tools we have: ventilators, dialyzers, medications, PPE, an especially acute part of the stuff pile in the last several months. Staff, how many people do we have who can do the work? So acute care trained physicians, acute care trained nurses, NPs, PAs, respiratory therapists, pharmacists, EMTs, and then other critical supporting staff who might be personally impacted, housekeeping staff, our administrative staff who may be affected either by exposure at work or at home. And then space, how much physical capacity do we have to care for patients? Are there alternate sites of care that we can use to care for critically ill patients, such as a PACU or an emergency department, or perhaps even a tent hospital? And then what's the available of space where we can safely care for patients with COVID-19, so negative pressure rooms? Overarching all three of these key pillars are systems of command, control, and communication. No one hospital exists in a vacuum, and we have to have a network that lets us care for patients in an organized fashion so that one hospital isn't getting slammed while two hospitals down the road have reasonable capacity and can continue to care for patients. Coordination between institutions allows you to minimize the impact of these episodes of catastrophe.
So I would say there are two basic types of respiratory support in COVID-19, non-invasive and invasive. And in the background of non-invasive over here, you have my colleague Maurizio Serreta, who's one of my friends and an expert in pulmonary physiology, wearing a helmet, a CPAP helmet. When you have non-invasive ventilation, the types here are essentially non-invasive CPAP, continuous positive airway pressure, or biphasic positive airway pressure, which can be delivered through nasal pillows, through a mask, or through a helmet, as you see here. And then there's also high-flow nasal oxygen, which some of us call high-flow nasal cannula. There's also invasive respiratory support through endotracheal intubation, whether that's nasal or oral, tracheostomy, or extracorporeal membrane oxygenation. When this is used in COVID-19, it's usually VV ECMO.
So overall, the goal for COVID-19 testing is to be able to test both symptomatic and asymptomatic individuals, because that's the key to reducing the spread of the virus. Presently in the United States, we test about 750,000 people each day, or approximately 5.25 million tests each week. And despite these increases in test capacity since the McKinsey report from May, the Rockefeller Foundation estimates that we need to test at least 30 million people each week by the fall of 2020. So the question arises, how will we achieve this goal? So the National Institutes of Health launched the RADx initiative earlier this year to develop, validate, improve, and implement testing to accelerate research development and implementation, particularly of point of care and other rapid testing for COVID-19. There's much more information on the RADx program on the NIH website.
We learned so much. Patients presented late, deteriorated quickly, and required high levels of care. Our respiratory therapists, critical care colleagues, and our surgical colleagues partnered to really evaluate when to perform tracheostomies and how to address weaning in the setting of prolonged critical illness. Advanced remote monitoring was required and upgraded. Many institutions have seen increases in central line-associated bloodstream infections, catheter-associated UTIs, and pressure injuries in the setting of decreased direct patient interactions, whether it be stretched staffing or initial recommendations aimed to decrease healthcare worker exposures. How do we provide what we know is best practice and hack prevention with the concurrent goal of healthcare worker safety?
The learning objectives are to apply standard oxygenation techniques, indicate when to use heated high-flow nasal cannula, and to review the rationale for and the role of awake proning in COVID-19 pneumonia. So we'll start off with a case. So this is a 48-year-old man with a history of diabetes. He presented to the hospital with 3 days of progressive fatigue and shortness of breath. His chest X-ray showed bilateral and pulmonary infiltrates, and his PCR for SARS was positive, after which he was diagnosed with COVID-19 pneumonia. On exam, his respiratory rate was 24, and his oxygen saturation was 86%, which improved to 92% with 3 liters of supplemental oxygen. The patient was then admitted to the medical floors, where you start to take care of him.